So, welcome everyone. We'll be joining in a couple of minutes. We've opened early to make sure everyone can join us in time. We have a large crowd registered. So, thank you very much, and we look forward to opening the webinar soon. So, welcome everyone. You can possibly hear the bells in the background of my noise here in the village where I live. This is the IGCS webinar. We are just waiting a couple of minutes to just make sure everyone can join, and then we'll be getting going very shortly. So, welcome everyone. My name is Julie Terode. I'm Director of the Institute of Cancer Policy, King's College London, and leading the work for the International Gynecologic Society on this Access series. Welcome to a very large audience from around the world. We've heard that there are over 500 people registered. So there's both global and local interest, demonstrating real readiness to learn from each other. Next slide, please. As the leading organisation for health professionals in gynecologic oncology, IGCS has stepped up and made a 5-year commitment to the global ambition to eliminate cervical cancer, mobilising its membership across the world to share both that global and local expertise. The Access Initiative, which stands for Accelerating Cervical Cancer Elimination Strategies Symposia, was created with one unifying vision that by 2030, every high-burden country will have a national cervical cancer elimination strategy that is actively being implemented. So I'm pleased to introduce Mary Aiken, the Chief Executive Officer of IGCS, to share more about the Access series.
Julie, thank you. And thank you all for taking the time today to join us. I'm grateful to Julie and to Heather Bryant, kind of my partners in crime here, and the faculty today, the IGCS Board of Directors, for all their support in letting us run with this concept of access. And of course, to my team, all of us who are committed to the elimination of cervical cancer. IGCS will host an Access Workshop Symposium at our annual meeting through 2030, with each event focusing on specific challenges and opportunities and policy environments of the host region. Our first symposium happened last year in Cape Town, South Africa. We're excited about this year in Montreal, and the following year, 2027, will be in Japan and then Latin America. Our true commitment to making this access program global and rotate that around the world. The goals of the symposia are to bring together representatives, clinicians, policymakers, and partners to advance the coordination of national access across the full care continuum while addressing these fragmented and siloed efforts to date. Through cross-sector dialogue, shared learning, access supports countries in advancing more of a coordinated context-specific approach aligned with the WHO 3 pillars of 90-70-90. Recently, in partnership with ICCP, IGCS contributed a wealth of information in the public domain via an online resource hub to centralize knowledge and best practice resources, along with a global map of national cancer elimination plans. Next slide. We encourage you to visit the IGCS website to view the map, the resources available, and definitely submit any additional materials that you have. We all know cervical cancer is one of the few cancers we have the best tools, yet eliminating it seems to be lost every year. That's why our Access Initiative and this webinar series, we hope, are very important to all of you. I'm going to give it back to Julie, and I'm super excited, Julie, to get it started.
Thanks very much, Marion. As advocates, we must keep pointing to the lives lost to this preventable cancer. So coming back to the series today, so building resilient systems towards cervical cancer elimination. This is a three-part summer webinar series that provides a pan-North American perspective on progress and sharing what's working and also what is not working as we work collectively to achieve elimination and get to that threshold of 400,000 women defined in the WHO Global Strategy. You've heard from Mary that the Access series will follow IGCS conferences around the globe. And for Access North America, I'm delighted to be co-chairing with Heather Brandt, Director of the HPV Cancer Prevention Program at St. Jude Children's Research Hospital. So thank you, Heather, for your contributions so far, and I look forward to working with you on this series. We have two parts today. We'll start with a snapshot of progress to date on elimination, and our speakers will be sharing their own insights to ensure programs and processes that we're building today are resilient across the years of delivery that need to follow. The second part of the webinar will take a deep dive on Pillar 3, the challenge on access to achieve the target of 90% of women with cervical cancer or pre-cancer receiving management promptly and at a high quality. So before we start, I encourage you to submit your questions in the Q&A feature on your Zoom control panel. We will do our best to address as many questions as possible as we go along. We are committed to recording this webinar and sharing it with you via YouTube. And so any questions we don't cover, we'll try and follow up with after the webinar. So it's my pleasure to introduce our first set of speakers who will bring a wealth of experience across cancer policy, elimination planning, and implementation. Firstly, we have Maurizio Maza, Advisor for Cancer Prevention and Control at PAHO, the Pan American Health Organization. Karen Kenfeller, who is a Professor of Public Health at the University of Sydney. Michelle Halligan, Director of Prevention, Performance, Measurement and Evaluation at the Canadian Partnership Against Cancer. And Tamika Felder, the Chief Visionary of Survivor. So thank you all for joining us today. So let's turn to our first presenter. Welcome Maurizio Maza, who will provide a regional snapshot on progress and trends. Over to you, Maurizio.
Thank you very much, Mary and Julie, for the invitation. We believe that this is a wonderful initiative that IGCS has started, and we're more than happy and honored to be part of it. So to begin with, I'd like to highlight that PAHO WHO has a series of cancer initiatives. The first one being the Childhood Cancer Initiative. Of course, we have the Global Breast Cancer Initiative, and with the collaboration of IARC, we've worked on the Latin American Code and Caribbean Code Against Cancer. But today, we're here to talk about the global strategy to accelerate the elimination of cervical cancer as a public health problem. Fortunately, the reason we can talk about eliminating cervical cancer, it's because we know it's a slow and well-defined natural history from the HPV infection to the pre-cancer to invasive cancer. providing us a clear window from the prevention through vaccination, through early detection, screening, and effective treatment before the cancer develops. And because of this, we have developed key pillars that we want to reach to accelerate elimination by the year 2030. We want to ensure that 90% of girls are fully vaccinated by the age of 15, that 70% of women are screened with a high performance test by 35 years of age and again by 45. And finally, that 90% of these women that have cervical disease can receive this at pre-cancer or even invasive cancer, with the main target of eventually being able to reach the incidence of less than 4 per 100,000 women. So fortunately for us as a region and part of PAHO's mandates, we have the plan of action for cervical cancer elimination, which is for 2018 to 2030. Very similar goals to that of elimination, but it was created before the elimination strategy, but it covers all the same pillars. And within PAHO, we have two key priorities of our director, which is better care for NCDs, which is strengthening the integration of NCDs into primary health care, which we believe is key to response to cervical cancer approach from a primary and secondary prevention aspect in healthcare. And then the Elimination Initiative, which promotes an integrated and sustainable approach to accelerate the elimination of over 30 diseases in our region. And fortunately, cervical cancer is one of those that's being prioritized. So to do the work, to be able to really identify the problems that we have as PAHO, as one of the many activities is we held regional workshops with collaborations of many of you that are here today with MD Anderson, with Florida International University, University of Miami, Basic Health International, to support countries and really identify how do we need to prioritize the actions around the different topics and our plan of action and elimination. You can see more details on the outcomes of this on a publication that Dr. Asara Benitez headed in Lancet Regional Americas discussing this. So at PAHO, we have developed a dashboard to track the progress of cervical cancer elimination in our region. So you can see that we look at the 90, 70, 90 targets. And if we look at a regional level, on the left side, you can see the different aspects of HPV vaccination, HPV screening, treatment, and the impact indicator. So in vaccination, you can see what the national immunization programs have HPV, if it's a single dose that's being used, and that transition is mainly happening throughout the region and also for girls and boys. Now we can see this trends. Has not been overnight. Fortunately, our region is one of the regions with one of the highest coverages. It'll be updated the 2025 soon, but we're over 70%, trying to reach those targets. Of course, for this meeting, we're looking at Canada and the US as examples of where they're at to begin with coverages above that 70%. But from a regional perspective, it's important to also highlight the challenges that we see, mainly in Caribbean countries, English-speaking Caribbean countries, where there's been a significant impact during the pandemic, and we need urgently to ensure that countries are currently working on getting back on track to the coverages that we need. Now, historically, we know the challenges that, for example, Colombia faced, as well as Mexico, due to the problems encountered on initial implementations or programmatic access to vaccines. But both countries, as you can see, are moving forward to come back and reach those goals. Late adopters like El Salvador can showcase that this can be done on a fairly short period of time. So as a region, we're very optimistic, right? And different countries are really almost getting to that target. And countries like Peru have actually achieved that, and we believe that they'll be able to sustain it for years to come. So as a region, as far as vaccination, we feel very positive that this is something that's going to be achievable. When we go to the screening, and again, look at the programmatic side of it, we know that most countries do have budgets for their programs, but mainly currently are cytology based. There is a transition, as you can see here, that VIA is being used less. But the idea is that we increase the HPV as a primary testing for most of them. Now, the estimated coverage, we know that Liabrumi and WHO is working, so we hope to update soon this dashboard. Now, as far as treatment, that is probably the most complicated one, since very few countries actually track really well what they do to those women that have an abnormal screening result or disease. We do know that there is a lot of capability in Latin America for the treatment and access to radiation and chemotherapy, but it's worth highlighting that the availability of radiation services in the Caribbean has a significant gap and it needs to be addressed to ensure that all the women that need service treatment can actually access it. So in general, when we look at the indicators and we have the US and Canada with the lowest burden of disease, despite all this progress, cervical cancer in the United States remains concentrated in underserved populations. And we know that women, even in rural and low income settings, have a big burden. The same in Canada. While HPV vaccination is high, it's important that challenges with vaccination and screening persist in indigenous populations in rural communities and low income settings. So you can see this, the progress overall of countries in this part of the dashboard. And if you want to look at country specific, there's also information. This is something that we are continuously updating, where you can see the information. This is an example, Argentina, or if you look into Costa Rica, and see how the country-specific information is there. And we expect to also include the cervical cancer guidelines or plans that are included within each country. So this is a work in progress to ensure that we can use this with member states and showcase the importance, because for us, it's important to not only look at the theory side of it, but work closely with the countries. We work closely with them and our partners to ensure that they do proper planning, that they have access to management. The PAHO region is increasing access to technologies. We're the region that provides over 30 countries procure HPV vaccine through us, as well as now including HPV testing and technologies for treatment. So overall, cervical cancer is definitely a priority for us and as a region. And again, I just want to thank IGCS for this invitation and for all the support that they provide PAHO in strengthening the capacity and management of women that have abnormal screening results with proper colposcopy management. So thank you very much for allowing me to share a little of our experience as a region.
Thank you so much, Mauricio, and I really applaud the extensive work done by PAHO to have this regional tracker. I'm sure people from other regions are going, wow, can we have that too? Be a great advocacy tool moving forward. And maybe you could add to the chat just how people can access that. We also had a question in the chat there, in the Q&A, about access to potential training courses that PAHO may have for clinicians and other health professionals. I know there are some, so I don't know if there's an extensive response or whether you'd just like to add it to the Q&A. I think people would be very interested to hear.
Okay, no, thank you. I'll put the dashboard. We have cervical cancer online through our virtual campus, but those will be updated. So new tools, we have a lot of new tools coming up in the next few months. So, but happy to share via the chat. Thank you.
And Asha's also asking how frequently are the data in the dashboard updated? I know the HPV vaccination data is quite quickly updated. Can you give a quick answer to that one?
Yeah, so for the quick one is the vaccine side, which is updated like yearly. So we'll have an update probably in the next coming weeks. For screening, it's right now we're using estimates. Unfortunately, there's a lot of deficiencies on the data. So a lot of what you see on the dashboard is the outcome of those regional workshops. It's not perfect, but it's our baseline. And moving forward, the idea is that every 2 years, all the information is going to be updated, right? But on a regular basis, we believe like every 6 months, we'll be able to provide new information and update the dashboard.
Okay, thank you very much. So keep an eye on the chat for those links. Thank you very much, Maurizio. Let's move now to Karen Camphel, and yeah, a big thank you for Karen, who is joining us on Sydney time, which anyone who's working globally will know it's not a good time to be awake. But thank you, Karen, and people are so interested to hear what you have to say. And particularly, we're going to hear from you about, what are the drivers of impact for as we move towards elimination.
Thank you so much, Julie, and thank you to Mary and the IGCS for the opportunity to talk to you today. And I'm going to, I suppose, take a little bit of a step back from Dr. Mars's presentation and just quickly go through the evidence base, very quickly go through the evidence base for elimination and talk about the importance, as has been said already, about acting on all three pillars, on all three fronts at once. So again, this life course, end-to-end approach is incredibly important when we're thinking about achieving elimination. These are my disclosures, which are investigator-initiated projects. So we all know the three pillars are 90, 70, 90. The only thing I would add to what's been said about those pillars is that when we're talking about I think there's a couple of things to say actually. Firstly, when we talk about 90, 70, 90, the 70% is actually a target for a minimum twice lifetime screening with a high performance test. And I really want to emphasize that the only high performance test is HPV primary screening at this moment in time. And that also that in many high-income countries, the targets have been conceived as achieving that 70% at more frequent intervals and up to 5-yearly screening. So countries are obviously adapting these targets as necessary, and this can be encapsulated in national or jurisdictional level elimination plans. The second point to make about 90, 70, 90 is that the last 90 is actually many 90s because there are many sub-treatment targets, right? There's the pre-invasive treatment target, there's the colposcopy target, there is the number of women actually that are candidates for surgery, receiving surgery at an early stage, chemotherapy, radiotherapy, and palliative care, and so on. So I think when we're thinking about monitoring and evaluation of elimination programs, it's incredibly important to be thinking about data systems that are capturing those linkages to care and not only pre-invasive treatment, but effective access to treatment for invasive cancer. And of course, the global strategy has been designed so that it's not only delivering a health impact to populations, but it delivers an economic benefit. And the return on investment in the global strategy is significant. It's been calculated across low and middle income countries. So even in a low and middle income country, it's $3.20 for every dollar invested through 2050. But actually that rises to $26 for every dollar invested if we think about the broader benefits of women being in the workforce, productive and contributing to society. So there's an incredible case to be made. And as Dr. Mars has said, there's a threshold for which we consider cervical cancer to be controlled as a public health problem, and that's 4 per 100,000 women per annum. But it's important to say that that doesn't mean we're done. It will always require that, at least for the foreseeable future, that active programmatic intervention, not only to reach the elimination threshold, but to reach it in all population groups and equitably, and also to keep rates under that level. So this is very quickly an illustration of why it's so important to act on all three fronts at once. This is an illustration of age-standardized mortality from cervical cancer across low and middle income countries. And the first depiction is what will happen over the next few decades if we only do vaccination. And you will see rates drop, but it takes a few decades to do that. Whereas if we add in the screening and treatment pillars, which are the green and purple simulations that you see, we can bring the benefits forward. And it's really treatment actually that will realise the most lives saved over the next decade in LMIC. And then screening will kick in over the intermediate period over the next 50 years. And then over the long-term, vaccination effects will kick in terms of cervical cancer mortality. And again, it's important to say that although we're seeing in high-income countries effects of vaccination on cervical cancer incidence and even potentially soon mortality in very young women, it's going to take decades for that to really take effect across the whole age spectrum of women with cervical cancer. So I just wanted to talk very briefly about an example, which is Australia, my own country, in terms of this idea of, again, acting across silos, end-to-end realisation, and also the idea that this is not one and done. We have to keep working at public health innovations in order to achieve elimination. And so Australia is on track to be the first country in the world to eliminate cervical cancer. There is a very good-hearted race going on now with Sweden, but hopefully both countries will do that in the very foreseeable future within the next decade. But this, I really wanted to illustrate with this figure how many different public health steps have been involved in positioning a country or jurisdiction towards elimination. So you can see here, it's everything from long-standing cervical screening, in Australia's case being one of the first 2 countries in the world in 2017 to transition to HPV-based screening. And then at the same time, the vaccination, early introduction 20 years ago of vaccination in girls, adding boys, and then moving to 2 and then 1 dose. So all of these aspects work together. And very quickly, I also wanted to show you some recent data. Maurizio's illustrated very clearly the power of having access to dashboard to monitor outcomes. And this is incredibly important. This is data from a report which is Australia's annual surveillance report on monitoring towards elimination, where there's many indicators and sub-indicators have been defined across the 3 pillars, including in priority population subgroups. And this is a recent snapshot showing that the screening coverage at 5-yearly HPV screening is over 74%, which is fantastic. And then on the right, I think I just really wanted to illustrate the power of self-collection for screening, which has really been a game changer and has been introduced a few years ago as a universal option for every single woman who's accessing cervical screening. And the short story with this figure is now half of women are choosing to self-collect rather than clinician collect. And even more importantly, that uptake is higher in priority populations that have been previously underserved. So all of this comes together. So again, this point being that it has to be acting on all 3 pillars to achieve elimination. And this is the modelling of the prospects in Australia, with the short story being that the elimination timing is predicted to be between 2028 and 2035. And this has really been then the focus and the impetus for putting together a national elimination strategy launched a few years ago, which really takes this as a target, but also defines not only this idea of reaching elimination on average at the population level by 2035, but actually starting to do so with an equity lens and thinking about initiatives that need to take place in various priority populations to achieve this. And just to finish, I also want to just touch on elimination timing in the USA. This is similar modelling that was done again a few years ago by the CISNET collaboration about the potential for elimination in the US. And this is 2 model analyses, but I think the short story here is that the US, given the current status quo, is expected to eliminate cervical cancer over the next 2 to 3 decades. But this could be really expedited by at least a decade or even more, particularly with a focus on screening and treatment access. So I think that's a key message. It's really screening and treatment, again, that are that accelerator of earlier timing to impact to elimination and to saving lives. So with that, I hope I've set the scene for what I'm sure will be a very interesting discussion today, and I will hand back to Julie. Thank you so much.
Wow, I mean, you really packed a lot into those few minutes, Karen. I'm seeing lots of positive responses in the chat. So thank you so much. I think you've given people some real inspiration to take some of these levers for change forward in their own setting. So thank you so much. I will now turn to our next speaker. We're moving to Canada. We've just seen some interesting timelines for the USA. What does it look like in Canada, Michelle? Over to you.
Hi, everyone. Thanks, Mary. Thanks, Julie and team for having us today from Canada to speak to you a little bit about our national plan. And we're pleased to have a national plan. So first and foremost, I'll start with some context. We are in a very good position in Canada to achieve elimination in my lifetime, which is pretty cool to say. I didn't start working in cancer prevention thinking that I'd be eliminating one. We are a nation where universal health care is delivered by 13 different provinces and territories. We've had robust cervical screening programs and school-based HPV immunization programs now for decades, and those vaccine programs are gender neutral in Canada. We also, in comparison to other nations, have quite robust cancer registries and increasing digital and interoperable health data that can support our action on the issue. And I'll come back to the data later on. So you can see here that cervical cancer incidence has fallen in Canada, thanks mostly to our organized screening programs and more recent introduction of the HPV vaccine. We're sitting now at about 8.7 per 100,000 women, so about halfway to that 4 threshold. We've seen rates recently bump up, which we are monitoring closely. Approximately 1,600 people, mostly women and individuals with a cervix in Canada, are being diagnosed each year, and more than 400 people die. And this is a tragedy given that this disease is preventable. And so as a result of WHO's global call for action, Canada co-created a national plan with hundreds of health experts, including Indigenous peoples in Canada, as well as patients. And our plan is more ambitious than the WHO's strategy, given how well positioned we are, with 90-90-90 targets for the 3 main pillars of vaccination, screening, and treatment. And similar to what Karen just shared about Australia, most importantly, this plan is centered on closing equity gaps to reach elimination in the country. This means focused work ahead with Indigenous populations and other equity-denied groups. Canada's plan was informed by data and modeling. Here you can see several scenarios optimizing the tools available, which will result in Canada eliminating cervical cancer well before the end of this century. The blue line you see here at the bottom is based on implementation of all actions outlined in Canada's plan. By doing so, elimination is possible in the next decade if we reach 90% vaccination and 90% screening rates with an HPV test. As such, we set Canada's goal to eliminate cervical cancer by the year of 2040. However, when it comes to HPV vaccination, despite great universal school-based programs, only one of our 13 jurisdictions has achieved the rate of vaccination necessary for elimination, pictured here in green on our East Coast. We know that there's great regional variation in vaccine coverage and that materially deprived populations are least likely to be vaccinated in Canada. And while Canada is moving to a 1-dose vaccination schedule, which may make the vaccine more acceptable to some, there's clearly still much work to do to boost vaccine confidence and shift mindsets that this vaccine represents one of the easiest ways to prevent cancer. Similarly, despite decades of organized screening programs, we aren't yet reaching the necessary screening participation rates. Canada sits at 69% uptake. Again, a lot of regional variation across our jurisdictions. The lowest screening rates in Canada are amongst newcomers, racialized populations, and people living with a disability. We will need to do more to reach never and under-screened populations. One tool that's offering some promise is self-screening, which is possible when HPV tests are adopted as the primary screening tool. Since 2020 and our launch of our action plan, we've seen tremendous progress across all regions in Canada towards implementation of HPV screening. Full adoption of HPV's primary screening is now underway in 3 jurisdictions shown here in gold, with 2 others closely following in blue. The remainder are planning for implementation in the coming years, the majority of which are planning to include self-screening. This shift represents an absolute game changer for Canada to achieve elimination and may support closing some of the equity gaps, such as bringing care closer to home in this very large country of ours, and perhaps more acceptable for some. And so elimination in Canada is a matter not only of time, but also making sure no one's left behind. HPV vaccines, screening, and timely follow-up need to be optimized in all corners of our vast country. We have 13 healthcare systems that need to be herded all in the right direction. I told you I'd come back to data. While we do have some data in Canada, we do need better data systems to support us in knowing exactly who we are missing so we can better allocate our finite resources there. In some parts of our country, believe it or not, we still rely on paper-based vaccine documentation. And most importantly, we need to work directly with diverse populations to better meet their needs in the delivery of our robust universal programs. We need to overcome ongoing barriers to access and acceptability of our life-saving HPV and screening programs. Ending on a positive, elimination in Canada is in sight, and I look forward to the day that we get there.
Thank you so much, Michelle, for that very clear snapshot from Canada. Also looking at different populations that we need to bring in to get behind the elimination story. But it's great to see the progress. And let's not forget, we've made good progress. And I think it's also encouraging to our international colleagues that have joined that it's always a work in progress. So I will move swiftly on to our last speaker for the first segment, Tamika Felder. And now from the survivor and patient perspective, what's your views on elimination, Tamika? Are you okay, Tamika? Do you need us to bring up slides?
Can you hear me?
We can.
Okay. Oh, there we go. Sorry about that.
No problem.
I saw something pop up on my screen. It confused me. Sorry. So in the interest of time, thank you all for having me here. It's really important for me to be able to share my story as someone who was diagnosed with cervical cancer 25 years ago, and also because of the people in my community. And so we're a global community of patient advocates, and here in the US, we want to make sure that every cervix matters and no one is left behind. We do that through our programs and our empowered survivor stories. For us, elimination is extremely important because we know that this needs to happen. In the United States, it's complicated. We know every state has different jurisdictions, but there are committed people in the United States who are working to make it happen. You'll hear from Dr. Heather Brandt later and many others who are working in the Southeast region, along with people who are doing great work in Louisiana and, of course, Alabama. In my role as co-chair of the ACS National Elimination Work Group, I'm happy to say that at our recent Dallas meeting, we were able to share the elimination framework. And while it isn't ready yet for public consumption, we're excited to be able to share that. And we know there is a lot of work that needs to be done in the US. We also want to make sure that we remind people that the patient voice is crucial in this movement, and it's extremely important. When I say every cervix matters, I mean that every single cervix matters. It also matters for the people who are no longer here to share their stories. We have to share their voices. No one should die, especially globally, but especially in the United States of America, of cervical cancer. So we have to eliminate. And even though it seems like we have a lot of work to do, we do have a lot of work to do. But just listening to the presentations, it's encouraging, it's promising, and we'll get there. Thank you so much.
Thank you so much, Tamika. And I love that every cervix matters. It really, really does. And the only way we're going to do this is to really focus on every single individual that we need to reach. So thank you very much to our speakers. Please feel free to continue sharing your comments or questions. But I now hand over to Heather Brandt to take us forward on Pillar 3. Heather.
Thank you so much, Julie, and thank you to our beginning presenters who have set the stage so nicely for our focus here now on the third treatment pillar. So if the team could pull up the slides, I'll get started while that's happening. So hi, everyone. I am Heather Brandt, and it's my pleasure to be chairing this portion of today's webinar, where we are going to turn our focus to the treatment pillar, ensuring that everyone who has cervical disease is receiving the care and support they need. So we're going to start again by setting the scene for the essential role of linkages to care and the systems required to ensure that everyone is getting that treatment and support. Then our panelists will share their regional perspectives and insights on management of cervical disease. So we're fortunate to have this outstanding group of experts joining us today to share their knowledge and work with us and also engage in discussion. So it's my pleasure to introduce Dr. Kathleen Schmaler of the University of Texas MD Anderson Cancer Center, Dr. Lucy Gilbert of the McGill University Health Center, Dr. Ashanda St. Jean of the New York Medical College, Dr. Jennifer Young Pierce of the University of Alabama Mitchell Cancer Institute, and Dr. Tiffany Zigris of the University of Toronto. So welcome all, and thank you so much for joining us today. We're going to get started with our first presentation with Dr. Schmeller, who is going to set the scene. And Dr. Schmeller, we see your note here about your video. We'll make sure we check that as you're sharing your slides. We can see you now. Welcome. Thank you. Go ahead and share, and we'll get started with this first presentation.
Great. Sorry, apologies. Am I sharing my slides or you're sharing them?
Yes, or we also have them backed up. Would you like for someone on the team to share them?
I have them. Unless you can do
no
it faster
problem.
than me. Sorry about that. I didn't realize that.
That's all right. Well, we had just a really great lead-in to this focus on the third pillar with some great background and resources, particularly impressed by the PAHO dashboard and some of the other tools that are available. And so now we get to focus our discussion more intently on that third pillar of treatment.
Can you see my slides?
We can see part of your screen right now currently.
How about now? You can't see the presentation?
Not yet. I do have them pulled up if you would like for me to share them. Oh, there we go. All right. Go ahead,
apologies
Kathleen.
for that.
No problem. Thank you.
So thanks so much, Heather and Mary and Julie and the IGCS team for this invitation. And I'm just going to give a very quick overview on the treatment of cervical cancer, and then many of my colleagues will be going into more depth. And I think, as we've heard, the more women we screen, the more pre-invasive and invasive cancers we'll find. So we need to make sure we have a plan for all these women who are found to have abnormal results. And I think a really important to that part of that is actually the need to include navigation strategies and processes for referral and treatment. And I'm a GYN oncologist, so I take care of invasive cancer, but I also do a lot of work in pre-invasive cancer. And we're losing many of those women with abnormal results in that phase where we could treat their pre-invasive disease. And then unfortunately myself and many of the other oncologists on the line are seeing these women with, unfortunately, locally advanced disease or worse, metastatic disease. The treatment modalities we use are surgery, radiation, chemotherapy, and now immunotherapy, and then, of course, palliative care if there isn't any treatment. So just a quick overview. This is the ideal when we diagnose disease in the precancerous phases. So in CIN, which stands for cervical intraepithelial neoplasia, grade 2 and 3 are the grades that can progress to cancer. And so those are the ones that we treat. In the US, we treat with excision with either a LEAP or LETS, those are the same thing, or a cold knife cone. A LEAP or a LETS is where we use a heated wire to remove the abnormal cells. And this can be done in a clinic using local anesthesia, so it doesn't require an operating room. There are now portable machines available, so we can take them from clinic to clinic if we're working in rural or underserved areas. And it provides a tissue specimen for diagnosis. Sometimes due to a patient's anatomy or for other reasons, we have to do this in the operating room. And certainly if we're worried about cancer, then we do what's called a cold knife cone, which is also an excision. It's just done with a scalpel in the operating room. In other countries, we commonly use thermal ablation, where instead of excising the abnormal cells, we treat them at a high temperature with thermal ablation, or we freeze them with cryotherapy. That's used much less commonly in the US because of our desire to have a specimen for review to make sure there's no underlying cancer. Unfortunately, pathology services are not widely available throughout the world. So thermal ablation and cryotherapy also work very well. If we do have invasive cancer, one of the most important things is to know the stage of that cancer. And that essentially lets us know if the cancer has spread or not. We use something called the FIGO staging system, which is our International Federation of Gynecology and Obstetrics. Stage goes from 1 to 4, 1 being very early stage and 4 being the highest or worst stage where there's cancer that has spread to other organs. Stage is important because it determines both the treatment that we do, but also the prognosis. So we can talk with our patients about the prognosis and treat different treatment options. And we determine stage by exam, a physical exam. How big is the tumor and does it involve surrounding tissues? We do biopsies and how the depth of invasion of the cancer, the things that the pathologists tell us play into the stage and the treatment. And then imaging studies. In high resource settings, we have scans such as MRI, CT scans, PETs, ultrasound. So that's how we determine the stage. If stage is very early, we can treat it with surgery, and surgery alone can cure it. And that can be a simple hysterectomy or radical hysterectomy. And there's lots of technical differences in this. And now we have many fertility sparing options for our young patients who want to preserve fertility should they have early stage disease. And that's something called radical trachelectomy. And now we do even more conservative surgery that Dr. Gilbert is going to talk about in her talk as well. If patients have disease, what we call locally advanced disease, so that's stage 1B3 to 4A, and that means that the cancer spread beyond the cervix, but it hasn't gone to the lungs or the liver or any distant organs. The great thing is these patients, even if they have big tumors, can still be cured with radiation therapy. Unfortunately, radiation therapy is not widely available in the world, but we're really lucky in the US and in North America that most patients have access to radiation therapy, although many times they have to travel for it. Radiation takes about 6 weeks. There's 2 parts to it. We do external beam radiation, where the patient comes every day, 5 days a week, Monday through Friday, and gets radiation treatment. And then at the end of that, they get what we call internal or intracavitary radiation with brachytherapy, where they get a very high dose right to where the tumor is. It's really important to have both of these. If you just do external beam, then it's not going to cure the cancer and will likely come back within 2 years. So very, very important to have both the external beam and the brachytherapy. With that, we give chemotherapy, cisplatin, that helps the radiation work better. So we call it a sensitizing chemotherapy. And now we also use immunotherapy in some cases too, which is like a chemotherapy, except works specifically on helping the immune system in fighting the cancer. And then if the cancer has spread beyond that, then we can use chemotherapy or immunotherapy. It's just important to know that chemotherapy alone won't cure cervical cancer. And then, of course, when we don't have any treatment options or when the cancer recurs, it's really, really important for our patients to have access to palliative care to alleviate the symptoms, but also to support quality and dignity at the end of life. The WHO and other groups have great benchmarks of how quickly all these things should happen, like time from visit to a facility to diagnosis of cancer within 4 weeks, kind of how fast to get the results. So there's great benchmarks out there for us to use. I think in North America, these are often met, certainly in the higher resource areas, but not always in our underserved parts of the countries. So I think just really important to keep in mind how important it is for us to get our patients back who have abnormal results and to do that quickly and with high quality tests and treatment. And again, I can't emphasize enough the importance of navigation and helping that either as the primary clinical team, but also with community navigators who often help us. So to make this happen, we need a multidisciplinary team. You can see here all the important members of that, not just the cancer specialists, but also the pathologists, radiologists, palliative care doctors, but pharmacists, nurses, social workers, and of course, navigators. Training and education is key, and the IGCS is at the forefront of leading that, both for pre-invasive disease as well as invasive cancer. And you can see here some pictures of our team. And I say the need is the same everywhere, whether it's in Zambia or in Indonesia or here in our home state of Texas. There's just a need for more providers to be able to do all the procedures necessary. I think important for a successful program is always at the top is the political commitment and funding. We spend a lot of time helping countries develop their cancer control plans and implement them. But we, are doing a terrible job, or we're doing a terrible job of that here at home. So we're really excited about this Access series and all the work that's being done to develop cancer control plans here in the US. And then, of course, the capacity building, data and monitoring systems, advocacy that we've heard a lot about, and then research for new tools. So I'll end there. I'll just show a picture of the team in Texas. I think a couple of people are on from the team, certainly Melissa Barone, but they are developing our Texas cervical cancer elimination plan together and are also really excited to be part of this series. Thank you.
Thank you so much, Kathleen. That was a great overview of the state of treatment and our opportunities to make sure that our efforts don't end with our prevention and identification of disease, that this piece is very important to achieving elimination. So next, we're going to go to Dr. Lucy Gilbert. So Dr. Gilbert, if you could come on screen and share your slides. We're looking forward to hearing from you to continue our focus on treatment. As Dr. Gilbert's pulling up her slides, we do want to give a shout out to our friends in Texas who are working on an elimination plan. We'll hear a little bit more about the first plan from Alabama from Dr. Young Pierce coming up here shortly. There's also a plan in Louisiana, which was referenced by Tamika, and several other plans in the works.
Can you see my slides?
Right now we see the outline view. We don't yet
Okay.
see the slideshow view.
Second, thank you.
You're all set. Thank you, Dr. Gilbert.
Thank you so much. So I want to thank all of you who have joined this. It means that you're determined to eliminate cervix cancer. And I think with everybody involved like this can be achieved. I'm going to talk about the Canadian perspective on treatment. We see patients after they've had the cancer, and in early stages, as Dr. Smeller alluded to, surgery is the key. And we used to do radical hysterectomy and sentinel lymph node mapping. I'm pleased that a Canadian team led a trial to de-escalate because these patients are very young, and a radical hysterectomy results in significant sexual dysfunction, urinary problems. And this trial, the SHAPE trial, showed that in selected patients with small tumor and less lymphovascular invasion, a simple hysterectomy and lymph node, sentinel lymph node dissection gets the same oncological outcome with significantly less sexual dysfunction and urinary symptoms. So that's remember that, or those of you who are invested in treating patients with early disease. Unfortunately, most patients come to us with advanced disease, and again, Kathleen said the standard of care is chemoradiation with cisplatin and external beam therapy and MRI-guided brachytherapy. The nice thing about Canada is that all of cervix cancers are treated in tertiary and quaternary care centers, and we tend to follow uniform guidelines, and patients get the same standard of care. For years, we've been treating patients with just concurrent chemoradiation, and then followed by chemotherapy. But the 40% of patients returned with recurrent disease and died within 5 years. And this is a patient, a 31-year-old, who was referred to us from outside our center. It's a usual story. She'd been complaining about bleeding, pain. Her obstetrician did many ultrasound scans and told her the baby is perfect, pregnancy is progressing well, but all along she had a cervix cancer. By the time she came to us, it had invaded the bladder, knocked off her ureters, caused bowel obstruction. And at this stage, we are firefighting. That's why what came in part 1 is the most important. So despite everything, she did progress and died last year, leaving a 4-year-old child. So we know this is not good enough. So we were part of this trial that looked at the addition of pembrolizumab immunotherapy to chemoradiation. And we showed, it was published in Lancet in 2024, it showed that this reduced the risk of death by 33%, and that's huge. And I have a patient who was in the trial with us, and you can see that when she came to us, the same story with her as well. It's the same story you hear again and again with people with invasive cancer, that either either they didn't access or they accessed screening and were not taken seriously. And this patient received chemoradiation with pembrolizumab. And I'm pleased to say that she was just seen a month ago. She continues, there's no evidence of disease. And immunotherapy makes this difference, that long after chemo and radiation, it continues to fight the cancer. Now, the reason I'm pleased to be in Canada is it's just not finding these wonderful treatments. It's making sure, and Kathleen spoke about it repeatedly, it's making sure that patients get this. They can navigate the system, and this works in Canada. And you can see that both the Canadian Drug Agency as well as the reimbursement agency in Quebec, the province I come from, have made this pembrolizumab available to all Canadians with locally advanced disease. However, this comes at a huge cost. You can see just the 230 patients in Quebec. For the next 3 years, we have added 25 million just by adding immunotherapy to their treatments for the small number of patients. So again, to emphasize, it's vaccination and screening that's much, much more important than this. And then making sure that everybody gets whatever is available. So my final slide, we do to compare how is Canada compared to others. We don't do as well as Australia because we see many more patients because our screening system hasn't quite come up to the mark. We see many more patients in Australia with locally advanced and distant disease, but we do better than the US, probably because of the single payer system. And this is reassuring statistics. Though we see much more locally advanced disease and distant disease than Australia, our 5-year survival rate is as much as that. And this is because every patient gets to a tertiary care center and gets the important treatments reimbursed. So we do better than US for that. Thank you so much.
Thank you so much, Dr. Gilbert. An important perspective to note here, the coverage that's available and the access that's available to this state-of-the-art care. Thank you for bringing that. Now we're going to hear from Dr. Ashanda Sanjan, who will be talking about cervical cancer treatment from the U.S. perspective. Dr. Sanjan?
Yes, thank you so much for this opportunity to present and really join this very important discussion about cervical cancer and how we move towards elimination, because it is possible, it is achievable. And just like my colleague Tamika Filster said, every cervix matters. So thank you a lot for allowing me to join this discussion. Oh, second, here we go. All right, so I'm just going to present firstly some stats here in the United States. So what we found is that, hold on one second, let me just move this over. Okay, why is this doing that? There we go. Okay, so we have 13,000 new cases of cervical cancer diagnosed each year in the United States, and over 4,000 women die from cervical cancer in the United States. So this is what we've talked about, is we should be eliminating this cancer, right? It is preventable, right? And how are we properly treating it, addressing it, and preventing it? So what we can also say is that cervical cancer remains one of the few cancers that is largely preventable. And I'm going to really focus on that word preventable, because when we talk about treatment should be preceded by prevention, right? And that way we can move towards elimination. But also what we must talk about is there are significant disparities that exist with cervical cancer detection, screening, and prevention among Black, Hispanic, rural, and underserved populations. And I say this most importantly because 20 years of my career was in New York City, right? And we understand there's a large concentration of healthcare providers, right? However, with the first wave of COVID, I moved upstate New York and I had my first encounter with rural settings. And so when we talk about, kind of inclusion for everyone, we have to have a conversation about rural settings, especially in the United States, because there are significant healthcare deserts that exist across our nation. So again, what we see is that nearly all cervical cancers are caused by persistent high-risk HPV infection. And we know the specific types are 16 and 18 that cause or account for approximately 70% of cervical cancers. And so when we think about vaccine, when we think about prevention, when we think about screening, when we think about elimination, and that's what the crux of what we're talking about today, is that we know that HPV vaccination reduces cervical cancer among the younger generations, but it also shows that cervical cancer rates among women who are vaccine eligible, we can decrease those numbers as well. So again, when we think about HPV vaccination, we have to think about the 9 HPV types, including 16 and 18. But they are responsible for most cervical cancers. And also what we understand is that the vaccine protects against HPV-related cancers that are other than cervix, right? So that includes anal, vulvar, vaginal, penile, and oropharyngeal. And what we can say here in the United States is that there's an 80% reduction in cervical precancerous lesions among vaccinated young women. And this fortifies that evidence that HPV vaccination not only prevents cervical cancer, but that's our way towards elimination of cervical cancer. Now, my colleagues who just preceded me, and I know I have a limited amount of time, talked about the different types of surgical intervention for early stage disease. And we have to remember surgery, again, remains the cornerstone of treatment for cervical cancer. And also, as we think about surgery, we have to also have within that lens is fertility preservation. So we have to also think about future fertility for our patients as well. And we want to keep that in mind when there's a design of the treatment plan that best fits the needs of our patients. And then also when we have locally advanced disease, again, whether we have to add that addition of chemoradiation therapy as well. So historically, when we think about the care, the treatment plan for recurrent or metastatic cervical cancer, we think about platinum-based chemotherapy, we think about the limited survival benefits. But today we have the ability to really adopt different therapies. We have immunotherapy, we have anti-antigenetic therapy, we have antibody drug conjugates, and we have biomarker-driven treatment selections. But we understand that there are advancements in the management of advanced cervical cancer, but we should also think about prevention, screening, and as we talk about in this conference is elimination. So when we think about what's happening in the United States, and this gets me excited because I think that when you look at certain medical care deserts, right? And I did not realize that until I moved upstate New York, and I had patients who told me that it would take an hour or 2 hours to just drive to see me because I was the only provider, not only in their insurance network, but that was closest to where they lived. And this is a real reality for so many people across our nation. So when we think about screening, we have to think about different modalities. And so what's happening in the United States is we are also expanding access through self-collection, right? Because again, not everyone has a provider who's able to do that screening through a pelvic exam. So we are looking at what the FDA approved as HPV self-collection and how that improves screening access, especially for those who have barriers to traditional pelvic exams. And we have to recognize that a pelvic exam is a very intimate exam, right? And so there are so many barriers in social determinants of health that impact our patients. And so how do we make it easier for us not only to have early detection, early diagnosis, but also to screen? And so what we found is that the American Cancer Society and other federal agencies have embraced self-collection of HPV screening. And again, that is how we address and reduce barriers to care, but also we increase access at the same time. And again, this is a major advancement in the United States in our strategy to prevent cervical cancer. And what we find as a potential benefit is, one, we're going to increase screening participation. We are going to have a greater reach to underserved communities. And therefore, we are reducing structural barriers. I think that, we have to recognize that not only are there barriers to screening, but once someone is diagnosed, there also could be barriers for them receiving care, oncologic care, so cancer treatment care. And that's another reality that so many people face. So again, when we think about this FDA approval of home screening, there's the Teal Health HPV test. Again, it's one of the first at-home cervical cancer screening tests, but it allows our patients to collect samples at home and submit them for HPV testing. And what we see as the potential impact is, again, we're going to have an uptake in screening. So that's going to improve our screening numbers. It's going to be more convenient for our patients, especially those in rural settings or who live in healthcare deserts, where they are not able to see or seek a professional, right? Because we understand that it's not only an OBGYN, even though that's what I am, who do pelvic exams. We have our nurse practitioners, our midwives, our family medicine docs, our ER docs, our primary care docs. But we have to also kind of really enter into that equation the social determinants of health. And those are non-medical factors that impact outcomes. And so expanding access will help with barriers to transportation, to childcare, and then just healthcare access barriers overall. So as we shift towards primary HPV testing, right, we understand that primary HPV testing can be over Pap testing alone or with co-testing, but we understand that it has a higher sensitivity, and then there's an early identification of high-risk disease. So it makes our screening intervals more efficient. And so when we think about elimination, we want to think about screening and prevention. We want to think about vaccination, but these are all modalities that we can use that would really lead us towards that elimination goal. So what's happening in the United States? HPV vaccination is working. We are seeing a decline in cervical cancer incidence among young women, but we're not done. This is not over. Every cervix matters. So again, we have to recognize that as we move towards cervical cancer elimination and recognize it as a public health problem, we have to also understand that vaccination, screening targets our achievement, which is our goal, our common goal of elimination of cervical cancer. So when we think about what our challenges are here in the United States, approximately 1 in 4 women are not up to date on their screening. We find that there's underscreening remains as the strongest risk factor for cervical cancer diagnosis. And then we also recognize that there are healthcare disparities and racial disparities among Black women, among Hispanic women, but also rural populations. And we see that across the United States. And then we have to also recognize that there are those that are underinsured or uninsured in totality. So What I will say is that as we move towards elimination, we strive together to not only look at what modalities we're using for screening, but also how we properly utilizing the HPV vaccination. Thank you so much.
Thank you so much, Ashanda. And you certainly brought to light in the United States the within region, within state, within jurisdiction inequities that exist. A lot of people think New York is just New York City. Rural northern New York, rural upstate New York are areas where we see gaps, and you identified several of those. Thank you for contributing that important perspective. Now we're going to move to our next presenter, Dr. Jennifer Young-Pierce, who's joining us here to share a little bit about the really front of the pack, leading the way work coming out of Alabama. Jennifer?
Hi, everyone. Thank you so much for the opportunity to talk about an incredible program that I have had the opportunity to participate in and get to share more with you about it. So I am a GYN oncologist at the University of South Alabama in Mobile, Alabama. And many of the challenges that we talk about in the United States, we are ground zero for both the challenges as well as the solutions. The population that I care for is over 30% African American, over 40% rural, and drives anywhere between 50 minutes and 3 hours to see me. The next major medical center is over 200 miles away. And so for each of these challenges, we are looking for ways to overcome it. I think as my colleagues have shared with you, unfortunately, and probably as the World Cup and the news coming out of the World Cup has shown you, the United States is united tiny countries. And unfortunately, we will not see United States-wide elimination plan because all of our states are so different and can have various differences. There are many similarities, as there are for all of us on this talk today, similarities across the international countries and across the United States, but there are differences both in resources and in opportunities. And so I present to you one example of what was done or what is being done in the state of Alabama and how that brings together the pieces of both prevention and treatment towards elimination. So Wipeout Cervical Cancer Alabama was the vision of two women. I do not claim to be one of them. Isabel Scarenzi here, pictured on the left, and Nancy Wright. Isabel Scarenzi is a professor at the University of Alabama in Birmingham and has long worked in cancer control and prevention for cervical cancer. Nancy Wright is the head of our cancer control for the Alabama Department of Public Health. And they came together early in 2021 after the WHO announcement and talked about a plan for elimination plan for the state of Alabama. And in that setting, they immediately brought together two very experienced international organizations. Together for Health is based out of Birmingham, Alabama, but also is an international organization working in cervical cancer screening. And of course, many of us are familiar with Rotary International, who is very familiar with vaccination on a global scale and who is almost single-handedly credited with the outreach and some of the funding that went towards the elimination of things like polio. And so they brought these organizations together to the table and created an announcement for cervical cancer, for a plan to put together cervical cancer elimination in the state of Alabama. That started with a summit in 2022, bringing together mainly primary care providers to see what they would need in these rural areas of the state to bring together findings for both prevention and getting patients referred for treatment. At the time that this occurred, we were ranked third for both incidence and mortality in the United States. And in addition to that, our vaccination rates were under the national average. In 2023, the plan was announced by our state health officer, Dr. Scott Harris. Essentially, for those of you outside the United States, that person is essentially the Surgeon General of the state. And Dr. Harris's support really radiated across the Southeast. We live in a very religious, conservative area, and for our state health officer to be the person announcing this elimination plan, as opposed to a more minor figure in academics or in medicine or in public health, would not have created the ripple that it did. And it was noticed not just obviously by our governor and legislature, but by other southern states that struggle to get widespread support for cervical cancer prevention, particularly with vaccination, but also, of course, screening and treatment. Of course, the Wipeout Alabama continued with the three pillars approach for 90% HPV vaccination, looking for school-based opportunities, Rotary support, and community education across the board. Cervical cancer screening to 90%. Largely an early on engagement of primary care at the outset, including the county health departments, a focus on health department participation, increasing evidence-based guidelines for provider education, including in both vaccination as well as screening, use of HPV as primary screening, opportunities for self-collection, etc., and a real focus on colposcopy services via nurse practitioners to the health departments. And so that kind of bridges that gap to follow-up, and we'll talk more about that, but ultimately getting follow-up and treatment to over 90%. So in Alabama, unfortunately, surgery is not the primary modality for treatment of cervical cancer because over 50% of women present as late stage. And so the treatment modalities are largely limited to chemotherapy and radiation, which again are at these centers for excellence in 3 major areas of our state, with most of our patients traveling greater than an hour to receive those treatments. So we really want to increase our follow-up. We really want to increase our treatment of early stage disease or pre-invasive disease to get patients to that 90%. In addition to that, for patients with advanced disease, to get that referral to an evidence-based center or to a center for excellence to that 90% goal. Because at the time of this announcement, greater than 50% of our patients with very advanced disease never saw a gynecologic oncologist. So there's a lot of opportunity here, and all of these pillars will be needed to eliminate cervical cancer in the state of Alabama. I love this slide. It took me a while to make it, but we have lots of partners across the state. I'm delighted that the University of South Alabama here, USA Mitchell in the right upper hand corner is a partner, but there are partners all over. And I wanted to make this slide to show you that none of us are operating in a vacuum. Wipeout Cervical Cancer Alabama does not have an office. It does not have a building. It does not employ tens or 20s of people. It is a group of partners who come together. Most of us do this a little bit as part of our day job, but a lot as a partner of the larger organizations. And so in that setting, I want you to take a look at this group and see what opportunities exist in your state, in your country, where you might find a partner, maybe a university, a health system, a doctor's office, maybe a payer system for those of us who have payers that are not government-based, maybe an NGO or someone working in something similar in women's health or in other areas, dental health, oral health, all of these are opportunities to partner. And of course, there's many more opportunities out there. This is just who's joined so far at over 45 in the first 3 years. And our progress. So we talked about pillars, we talked about partners, and last, our progress. So far, we have had 3 statewide summits, the original summit in 2022, the announcement in 23. From there, we actually did 12 regional trainings across the state. We went to the providers. We encouraged them with evidence-based information on improving their counseling regarding vaccination, on use of HPV-based testing, on why we need HPV tests even when a woman has a normal PAP or is up to date on her PAP screening, and ultimately the utilization of HPV vaccination after treatment. We talked about all of these options. And then we held statewide summits again in 25 and 26. Most recently here at the University of South Alabama in Mobile on January 9th, we had over 150 people in attendance. And at that time, we also did and have continued to do champion trainings around the state. Our champion trainings are 2 to 3 hours long with role play and feedback to really help people to be able to advocate. This is patients, this is businessmen, this is people who work in NGOs, people who work in government, people who work in healthcare facilities, to train them how to talk to people about vaccination, to talk to people about screening, to talk to people about the newest evidence, and ultimately to be an advocate for elimination in our state. The biggest advance in progress that we have had to date has to be the rollout of nurse practitioners to county health departments to provide colposcopy services. Prior to this, we had 23 counties without an OBGYN provider of any kind and 35 counties without colposcopy services. Now all 67 counties can be reached by colposcopy services, and that has resulted in going from around 200, maybe 250 colposcopies provided by the state health departments, the others provided in those large center for excellence in big cities, now to almost 1,200 colposcopies in the state of Alabama provided in these local health departments by a team of nurse practitioners led by Dr. Gary Pugh, and who ultimately are doing this locally. And that has taken our follow-up from 30% at the big centers to over 75% in the local health department. So we're really starting to get there with that improvement and follow-up, ultimately leading to treatment of early disease, pre-invasive disease, rather than a late-stage diagnosis. We are still working on increasing referral and treatment for patients with a cervical cancer diagnosis. As Dr. St. John mentioned, we have so many new modalities to treat patients with very advanced disease. We want to encourage people that even though these centers for excellence are a bit of a drive, they are worth the drive. And we are busy educating our local medical oncologists on the benefits of immunotherapy, the ADCs like Tivdak that we talked about, and these other newer modalities that can really impact patient care. Last, I just want to show a little bit of our progress, and we have seen significant improvements in our vaccination and stabilization of our vaccination rates over that time during COVID when they have tended to go down, and a decrease in our incidence and mortality. So we're just really excited about that. We encourage all of you to get motivated towards elimination, whether that is at an individual level or as a group, and to build those coalitions that work together for partnership.
Thank you so much, Dr. Pierce. Great look at the work that Alabama has done. I know we'll get to hear from Dr. Scarinci in the second webinar in this three-part series and learn more. Let's go ahead and transition to our final presenter for today, Dr. Tiffany Zegras, who's going to share with us the perspective from Ontario and the work that they've been doing in managing HPV results. Dr. Zegras.
Thank you. You can hear me okay?
Yes, you
Great.
sound
Okay.
great, look great.
Okay, thanks so much. So we're going to switch gears a little bit. I'm going to speak mostly about management of an HPV positive result, and I'm going to focus on Ontario's approach. I am similarly a gynecologic oncologist working out of Mississauga, Ontario, and I'm an assistant professor at the University of Toronto. I'm also the provincial lead for our Ontario cervical screening program and colposcopy services through Ontario Health and Cancer Care Ontario. So going to show you a little bit of a snapshot of the work that we do as part of that program. So I know actually Michelle put up this slide earlier during the Canadian portion of the talk in part one, and I just wanted to kind of set the scene for Canada. We're quite similar to the US in that every province acts like its own little country, and even though we have universal health care, the funding for healthcare happens at the provincial level. So that means that the healthcare services are decided on by the province independently. So Canada doesn't really have a standard approach at the moment. So PEI, which is a very tiny province all the way on the east side of the country, launched HPV testing first in May of 2023, followed by British Columbia all the way over on the west side of our country back in January of 2024. We in Ontario launched in March of 2025, and Alberta has done a partial implementation, as well as Quebec and the Northwestern Territories have done partial implementation of HPV testing. The remainder of the provinces have plans to implement HPV testing, but they're not yet there. So you can see it's quite a bit of a patchwork across our country. And that does affect how we work towards our elimination goal. And I'm going to focus a little bit on Ontario, just as that's kind of my area. So we have an organized screening program, and I know screening is going to be the focus of the second webinar, but just to say that when we participate as an organized screening program, we do have a lot of benefits because there's a lot of program and data evaluation that takes place, a lot of measurement. I've just taken on this role as the provincial lead in January, and I've been blown away by how many people are working behind the scenes to measure screening, how many screening participants we have, what are the results of those screens, how many people are getting treatment. We also do a lot of work in terms of quality reporting to our colposcopy facilities and to our colposcopists. And as part of our screening programs, we also provide correspondence to our patients to invite them to participate, as well as providing them with correspondence with their results. And so those are kind of key pieces to try to bridge some of those gaps that exist in terms of getting people screened and also getting them to their proper treatment. So if they have an HPV positive result that requires colposcopy, they will receive a letter advising them of that. As I mentioned, we launched primary HPV testing in March of 2025. So we're just over a year. We've actually hit over 1 million people tested with HPV tests in our province. And we've also implemented some self-collection. We are actually evaluating our self-collection as we go and doing some lab analysis before we go full scale. But it is our plan to offer all participants of screening in the province self-collection in the near future. We've spoken a lot, and Dr. Schmaler, I believe, mentioned how important navigation is as part of kind of screening to results to treatment. And in our province, for better or for worse, we do rely on primary care providers as our navigators. So they are kind of the main gatekeeper in our province. And, you know, that can be debated if that is the best strategy. As we know that Canadians these days, about 15 to 20% might not have a primary care provider. But historically, our healthcare system has relied on primary care providers to be their navigators with respect to screening and access to specialists and things like that. So we moved to risk stratified triaging, similar to what is done with the ASCCP, using genotyping and cytology as our triage tests. And so the important thing to know is that not all people with a high-risk HPV positive test will come into colposcopy. They have to meet a threshold. In our province, we set the goal of equal to or greater than 6% risk of immediate CIN3 to enter into colposcopy. And so if you don't meet that threshold, then you're going to have a repeat screening test with your primary care provider. And then depending on those results, you may come into colposcopy or you may return to average risk screening, which would be in 5 years if your HPV is negative on the repeat. But if you have HPV 16 or 18 positive, or if you have HPV other with a high-grade cytology, then you're coming into colposcopy for assessment. And this is just a really kind of bird's eye view of what things might look like for you in colposcopy. If you come in with a low-grade cytology and we don't find a high-grade lesion, then you're going to be discharged back to primary care for a short interval follow-up. But if you come in with a high-grade cytology, if we assess your cervix and we find a lesion there, we're obviously going to go ahead and treat it, and you'll have some post-treatment surveillance. If we don't initially identify a high-grade lesion, but you've come in with a high-grade cytology, we don't automatically discharge you. We will see you one more time, usually about a year later. And then again, if we don't see a high-grade lesion, then you'll be discharged back, because there is a few people who might come in with high-grade on their cytology that don't actually have a lesion that needs to be treated. So we do have to balance the risks of colposcopy with obviously the benefits as well. And I know we've spoken about kind of treatment in some of the earlier slides, and I'll try to briefly summarize that we similarly to what Dr. Schmaler mentioned in Canada, prefer excisional procedures. So if somebody has HSIL, we would recommend a LEAP or a cold knife cone. Laser can for sure be considered if the colposcopy is adequate and the ECC was negative. We generally are not recommending cryotherapy. Again, we have this preference for tissue. because we want to have that pathology result, but obviously the mode of treatment is at the discretion of the treating colposcopist. AIS is treated with excisional procedure, and if margins are positive, a re-excision can be considered, and certainly a hysterectomy can also be considered based on patient factors. And of course, in early cervical cancer, if a microinvasive cancer is identified during colposcopy, we do recommend excisional procedure, and then typically these patients are referred to gynecologic oncology for fertility sparing conversations depending on their age versus hysterectomy plus or minus nodes, again, depending on the final pathology result. Follow-up usually includes co-testing in our province. So everybody would get a co-test at 6 months and 12 months for HSIL. If you have AIS or cancer, then of course there's more intensive surveillance post-treatment. And those that have 2 negative HPV tests can be discharged back to primary care with a repeat screen in 5 years. And so is Canada on track to have our elimination projections met? And I know Michelle also showed this slide earlier in part 1 of the talk. And I think, we are in a good place, but it's not a guarantee. I think that, from our provincial data, participation is pretty fixed at 60% in terms of screening participation. And these projections are showing that we need to have screening at 70% with an HPV test. So that means that all the provinces across Canada need to get all of their patients getting HPV testing up to 70%. And we're for some reason struggling, despite all of our best efforts to get people screened. We're struggling to get our screening rates above 60%, at least in Ontario. And this is quite similar across many other jurisdictions. So even with universal healthcare, the test is paid for. People have family doctors, although not everybody. We just still can't get our participation rates as high as we like them to. So we are in a good place, but it's not a guarantee. And so we have to continue to work on this daily to get to our elimination goals. And of course, I think something that has been articulated by many of the speakers on the call is the equity piece and bridging the gap for some of those barriers, like those that are living in rural areas. And so we do see self-sampling as a huge opportunity to try to close some of those gaps, but I don't think it's going to answer the whole story. And so with that, I know we've gone way over time this afternoon. I want to thank you, and I'm happy to speak more during the panel discussion.
Thank you so much, Tiffany. We have come to the end of our time, and we are going to have to skip over the moderated panel discussion. But for our presenters who are able to do so, I would love for you to answer the question in the chat that from your perspective, if we fast forward to 10 years from now or 2040 as the Canadian benchmark here, what one treatment system change will have made the greatest difference in achieving elimination? So I would like to invite you to add that to the chat to send to everyone as we wrap up today. It's been a pleasure to work with Julie Terode and the IGCS team and all of you on this introduction to the treatment pillar as a fundamental part of our elimination planning efforts. So I am going to turn things over to Julie to wrap us up here for webinar 1, but do invite all of you who are presenters to answer that final question in the chat if you're able to do so. Julie?
Thanks very much, Heather, and thank you to all of our speakers. We have covered so much ground today, and it's been really interesting to have a deep dive on the treatment pillar. Often gets forgotten in conversations, and we did promise you, Kathleen, right? We would start on treatment in the next meeting, and I think it's been very interesting. We've had so many positive comments on the chat, so even if you haven't been able to look as you've been presenting, there have maybe not as many questions there, but people have really been inspired by what you've been sharing. So I think we can stop there. I think I can see Mary's very happy. So thank you, everyone. And please sign up and join us for webinar 2, where we'll be taking a deeper dive into screening and treatment. Thank you, everyone.